Thank you, Gilson, and thank you everyone for coming to this session. May I remark that in most forums around the world, this session, this type of session, has become the most popular. It's probably popular because it comes to the heart of the management of our patients, beyond the pharmacotherapy, beyond devices. What can we do as teams to improve the health outcomes of individuals who have complex health issues and needs? So when I first started talking to a conference like this, there would be a few people in the room, and over the years I've seen a healthy increase in the number of people, and I'm delighted that we have a good audience today to hear about the evidence, and particularly to think maybe in our next presentation about the Middle East, and of course I co-chair talking from a South American perspective. My job today is just to give you an update on what the heart failure management programs, what does the evidence really tell us? And the evidence is quite rich, but in the end you can see it's quite perplexing as well. So if we just start, I was grateful for Pim Remmer providing one of my early slides looking at the fact that heart failure is indeed more malignant than cancer. We did actually follow this up recently with an analysis of the impact of heart disease, particularly acute myocardial infarction and heart failure in the Swedish population, reason being they have very good data. But here you can look in a whole population, in both men and women, the most common forms of cancer. Here's the numbers over a period of time, and then you have acute myocardial infarction, and then you have heart failure. No matter which way you look at it, heart failure is a substantial burden on the healthcare system at a population level. I've been privileged to work around the world, and in every continent that I've been to visit people in the home who live with heart failure, and to see how they deal with it. And it's remarkable, no matter what our colour, our culture, our religion, heart failure has the same impact on that individual, very profound impact on their life, a poor quality of life, high risk of hospitalisation, lots of treatment, and of course a risk of increased mortality of a premature death. This is just one lady that we've helped recently. This is Fiona, one of our nurses back in Melbourne, Australia. But this is a lady, Betty, who's actually made it to 90 years old. She's been out of hospital for 3 years now. And the other week she, do you know a bucket list before you die? On her bucket list was to be on TV. And I'm glad to say she made it on TV at the ripe old age of 90. I think that's what most of us would want, to be healthy, to be out of hospital and doing the things we'd like to do. It's good for the individual, and it's also good for the healthcare system because it costs less money. If we're going to live longer, we have to live cost effectively, if you like. So what does the data tell us? So I'm going to go through a few things with you. The first is the old evidence of multidisciplinary management. Does it still hold true today? The Which-1 trial that we published recently, why did we need it and what did it tell us? Integrating remote monitoring biomarkers in individualised care, why do we need things like the Which-2 trial, which is a sort of summary of what we're doing, and what might it tell us? And then looking at the increasing complexity and multimorbidity in chronic heart failure, why we need new trials looking at the needs of patients with even more complex problems now that we're dealing with those with simpler problems. So if we just look at the case for heart failure management, remind you there's a very rich and evolving evidence base of randomised controlled trials that demonstrated reduced readmissions and prolonged survival, improved quality of life, patient and carer empowerment, reduced healthcare costs. And indeed, meta-analyses back all the way through 2004 demonstrated this, so that showed the combined evidence of trials showing benefits. And I'm going to go through that carefully. But to remind you from an ESC point of view, that heart failure management programs have reached the highest level of evidence for support. So they should be provided to all patients who've been hospitalised with heart failure. Are they? Probably not. Should they? Probably yes. So what about that specific evidence? And we published, myself along with Finlay McAllister and John McMurray published a meta-analysis and really quite showed whether you looked at the line of unity here, predominantly programs that had multidisciplinary heart failure care were better than those looking at telephone alone. Just put that to there so that we had a range of programs, including Michael Rich's initial publication in the New England Journal and our own from the Lancet, showing predominantly a prolongation of survival. And in actual fact, if you looked at the risk of readmission, exactly the same relative risk reduction. Around 20 to 30% risk reduction of mortality and of risk of readmission. So here's the management and readmission to show it again. Interestingly enough, and this is interesting, the new evidence coming out with telephone support showed no benefit in terms of all-cause readmissions. But in terms of the all-cause readmissions, once again, multidisciplinary programs seem to have the most benefits. To tease this out a little bit more, who I would regard as the heart failure management mafia got together and combined their studies into an individual analysis from their trials to see what actually works in heart failure. And here are the people. It's interesting, the same people have got together for the last trial I'm going to show you. Many of the same people have got together. So we compete with each other to determine which is the best model of care, but in actual fact we collaborate quite closely also to see what the best model of care. So what we did is we looked at the program delivery we had in standard care versus management. So remembering we were looking at standard management versus usual care, the more model of care. And we basically said we can account for most things, including education and counselling, the environment in which we manage, program recipient, intensity, complexity of follow-up, and the medication. But there were differences, and we had 3 trials that used a single heart failure expert and telephone communication, so a person on the end of a phone. Had 3 trials using a single expert, but in person. And we had 4 trials that used a multidisciplinary team and in-person communication. So this is important, the way that we've looked at the evidence before. And what we found was this, and this is pretty simple. We had the 3 comparators here, the single expert and telephone, the single expert and in-person, and the team and in-person. And here's looking relative readmissions per month and days of readmissions, so both readmissions per se and then length of stay, relative to usual standard care. That was the impact when you had the single expert on the phone, that was the impact when you had a single expert in person, and that was the team in person. So a stepwise benefit from having in-person management of heart failure with a team approach. Unequivocal that the best way to improve health outcomes in person and in teams if you can deliver it that way. That led us to the question, in person. We knew the characteristics and components of management programs for patients with heart failure, and would I say, very importantly to you right here, right now, that heart failure management programs are the one treatment therapeutic that spans the divide between small hearts and big hearts, preserved ejection fraction and reduced ejection fraction. It makes no differentiation between. If you are at risk of readmission and premature mortality, heart failure management works. But anyway, we knew the characteristics, and these are a long line of characteristics. I'm happy to share the slides with you later. But we knew what the components were. What we didn't know was how. So you can either have home visits, of course. You can have specialist clinics, particularly favoured by the Swedish mafia and the North American mafia, if you like. And then you have telemonitoring and telephone care, and that's not really what we were about. You have all of these components there on the left of you, but but in actual fact, we were doing the which trial, which is home versus clinic-based management of heart failure. Which one of those components, when delivered in the home or via a specialist clinic, was going to make a difference. So we undertook a multi-centre trial. It was consort compliant. This is really important for the trials we're undertaking now. They have to be rigorous. We had block randomisation, so it was stratified for HFrEF and HFpEF, preserved and reduced ejection fraction. We had an independent data management team, standardised care, either via experienced heart failure clinics with no home visits or outreach home visits. And we had blinded endpoint adjudication and acquisition. So this was a very well run trial. Remembering, however, in these trials, they are non-blinded from the intervention. That's the one weakness you have with this. So what were the results? I'm going to show you the prolonged results. So we published our first results in JACC, but we've recently updated, and what we looked at was over 3 to 5 years, which one was better. And here we have clinic will be in blue and home-based in red. And as you can see from here, the home-based intervention had 45 more all-cause readmissions, so about 300 patients in the study. However, when you then look at hospital stay, the rate of hospital stay was dramatically different between clinic-based and home-based intervention. And indeed, the difference between two groups, with around 150 patients in each group, was 1,300 less days of all-cause hospital stay. So there was a profound difference in the home-based intervention with hospital stay. And the second very surprising result was this: survival. Survival curve here, Kaplan-Meier survival out up to about 5 years. You can see in blue the clinic-based intervention and then the home-based intervention. And the point of difference in all of our trials has been a critical home visit at 7 to 14 days post-discharge, and the two survival curves from all of our trials always different right here. You can hardly see it, but the early mortality within the first 3 or 4 days, 7 days, is similar, and then survival starts to diverge when you get to the point of doing a home visit. So in actual fact, on an adjusted basis, there was a difference, a relative risk reduction of almost 40% mortality in favour of the home-based intervention. Put that in absolute terms, there were 20 less deaths in the home-based intervention group. This is not a case, as you may know, with RELAX and the RELAX-2 trial with serelaxin deciding to add a death here or there and determining whether or not there's a mortality benefit. There was a clear mortality benefit with the home-based intervention. So what about telephone versus telemonitoring? Well, we've published a number of meta-analyses showing that there are probably benefits from this type of approach, but it's very heart failure specific. So if you look at all-cause mortality, you might get a small benefit, but in terms of all-cause readmissions, it's not. And I want to explain that in a minute. We did update it though, and if you look at the publication from both an American group and from a European group, from the Tele HF study and the TIM HF study, either using a telephone support or telemonitoring, there really wasn't much difference. And I apologise for the red on blue, but essentially it seemed that these studies still cast a doubt whether or not they should be the primary. So we're talking about telephone care or telephone monitoring should really not be the primary mode of management of patients with heart failure. It should be ancillary to in-person care if you can get away with it. If you can't reach someone personally, then of course those strategies should work for you. What about BNP monitoring? So everyone wants to have a new biomarker, of course, and I heard it mentioned in the last talks about BNP. BNP is fine in younger patients, but as soon as you get to patients who've got renal failure, atrial fibrillation, all of those things that might elevate the BNP, it does get a little bit of complex. And back in 2006, there was this sort of initial optimism around it, tempered by qualified support. Now, so the guidelines were sitting around a grade B recommendation, which sort of said this is a good idea, but not quite there. If you may remember, a new systematic review has come out in European heart failure that showed, in actual fact, if you put the evidence together, that BNP probably does help you delineate between who is still at risk, who's overcompensated, that's decompensating, that needs to have more aggressive management in heart failure therapy. But do you know what? We haven't had many trials that have looked at this very clearly. There has been a couple, but I think this is still something that needs to be investigated further. Which probably brings us to this trial, which is now, remembering the witch trial, you've seen this schema already. What we're actually interested in now is, can you apply a one-size-fits-all, or do you need to delineate risk and titrate management using things like BNP and other smart predictors of outcome? And this is the subject of the Witch 2 trial. I don't want to bore you too much, but this is the design of the Witch 2 trial. But essentially what we have here is a large randomized trial of up to 800 patients. We're actually up to 450 as we speak in Australia, looking at standard management. And this is standard management at gold standard. So this is with home visits and clinic support versus a titrated management using a traffic light approach. And I'll talk to you about that in a minute. But essentially, it's a very complicated way of stratifying our patients, trying to give more care to those who need it most. So this does hinge on this thing called the Guardian CHF guided management tool. But essentially, we use a green, amber, red delineation of future risk, and we rely on three domains. One is clinical stability, the other is the adequacy of management, and the other one is a more holistic status around the patient and their families about what they need. So it's actually derived from the Witch trial, but I can tell you we're integrating BNP markers. We can use any markers in that. If they're elevated, we measure BNP. We actually use structured telephone support as well as in-home visits. Now, the remarkable thing about this study is that in Australia, if you want to visit a patient in the home, sometimes it takes 7 hours to get there. Well, guess what? We actually do either fly or drive for 7 hours to see a patient if they're high risk. So this is about giving the most, no matter where you live, whether or not that'll make a difference. So this is about achieving cost effectiveness in the management studies. And I just want to finish up now about the issue of multimorbidity. This is actually data from 600 patients combined in which showing that there are clusters of conditions in heart failure. Our patients, at least in Australia, and I'm told the same in America, we validated this in America, are becoming increasingly complex. In other words, we're helping them live longer, and they live longer, they're developing all these comorbidities. If you look at the typical distribution in both men and women, you can see the majority of patients have 4 or 5 comorbidities that complicate treatment. And we've developed now this matrix called the Conundrum heart failure matrix, identifying the 10 most common conditions that complicate heart failure management, and demonstrated that in actual fact, beyond some of the, for example, impaired erythropoiesis when you've got thyroid disease and develop anemia, beyond the pathological mechanisms that derive these clusters, there are probably interventions that are non-heart failure specific that will have 2 impacts. One, that will improve the knock-on comorbidity. For example, if you get better sleep, you will less likely be anxious and depressed. But 2, you'll actually improve your heart failure management. And the old consortia, the old heart failure mafia have got together for the Conundrum heart failure trial. We're just designing it right now. But this is a study designed to impact upon multimorbidity in heart failure. So watch this space. So in summary, I can say the primary evidence in favour of post-discharge heart failure management programs was established 10 years ago. So we really don't need to be having a debate about whether they should be applied. It really should be about how they're applied. Since then, many attempts have been made to diversify the approaches and selectively apply the evidence. So, for example, some people have taken the funding from heart failure management and said, oh, well, that will work for cardiac rehabilitation. That is not the case. heart failure management programs have a particular place in the spectrum of the management of heart failure and should not be transplanted with other money into other programs where the evidence is much slimmer and is less equivocal. We do need head-to-head trials such as the witch trial, and I didn't have time to show you, but the coach trial, my good friend Professor Tina Jasva from Sweden. There are groups of people who have moved on from trying to prove the primary evidence for heart failure management into what actually works to increase the cost efficacy. There are commercial attempts, I think, to add devices and biomarkers, but I think we need to be really cautious about this review and uptake. The majority of the management programs are cost effective, but if you start adding costly devices, unless they're added to people with already devices, and if you want to use biomarkers, I will want to be very sure that that actually does improve health outcomes rather than pay some money to a company who sells the device or sells the biomarker. I would be very, very careful of that, and yet I see that those people are making a lot of noise, but it does worry me. And remembering, we need to individualise care and apply new evidence. So the Witch-2 trial and Conundrum, they represent the next phase of research. We need to be continuing to strive to improve health outcomes. And that's why I would say to you the Conundrum trial represents the next step too. And I'm really pleased that we have a collaboration between European, American and Australian researchers, and I know CMU's here. We've had connections with the Hong Kong people, that this is a global issue, right? It shouldn't be us in silos. We need to be talking to each other about what works best to make sure we improve health outcomes. Remembering, if we come back to what I said, heart failure is heart failure, whether or not it's here in the Middle East, whether it's in sub-Saharan Africa, in Antarctica. It is the same thing, and we need to strive for the same model of care. And I'll just finish, though, with this important caveat. We could have all the guidelines we like, and it is all about teamwork. But unless that team is talking to each other, you may not necessarily get the best health outcomes. So thank you very much.
Okay. You would like some questions? Okay, please, go on ahead.
Enjoyed very much your excellent presentation and the information you gave us about this multidisciplinary approach to these senior people. And certainly that has resulted into improved survival to them.
Yep.
But the question, did that translate into a better quality of life to these people?
Yes, it does. I think we can demonstrate that on quality of life indices. It's always difficult to get the measure, but you can actually show that rather than getting improvements in quality of life, what you do is you hold the line, because remembering with heart failure you tend to get that progressive worsening. And you also get a worsening of quality of life around rehospitalization, so decompensation or another event. So we can clearly demonstrate that the patients are happy. We had an interesting exercise in the last trial we did where we did a discrete choice experiment, and we said, how much would you pay to either have the clinic or the home management? Now, remembering the people who had the clinic didn't know what the home was like. Okay, so in actual fact, it turned out 50-50. The people who got the clinic management said, I would prefer the clinic management. And then we said, well, what about the home? And they said, I would like that. So depending on the group, you gravitated towards that group. However, the people who had the home-based intervention actually were prepared to pay 10 times more for that service if they had to pay. So I think you can put a dollar value on it. The dollar value is people, the individuals who you do this work for, they feel so much more supported. And in actual fact, it's the intrinsic in-person management, I believe, is the most therapeutic. It's not the drugs. We can do the drugs anyway. It's actually that we care. And especially when a doctor and a nurse and a pharmacist all get together and say, we care, we're here for you, then they're happier and you get better health outcomes. And that's intrinsically, to me, is why I'm in health in the first place.
Okay.
have been hearing since long time heart failure as a malignant syndrome. How do you define malignant? Do you have a benign heart failure syndrome?
No, you don't.
Because we have heart failure with small heart,
Yep.
severe systolic dysfunction. We call this as a tiger heart failure syndrome. On the other end, we have a large heart with severe systolic dysfunction as an elephant heart failure syndrome. So which one is benign, which one is malignant?
Okay, so part of the reason for calling it malignant is that with the story around cancers, that you have cancer, and no matter, even if you have a really good survival prospect, you're expected to die, and any survival from that, you're a survivor. So this is about a public awareness. Malignant is a term to the public that's very evocative. So when we talk about more malignant than cancer, we were actually saying general survival rates in heart failure as a general population are worse than many forms of cancer, and that's still true today. On an individual basis, a person may not be at risk of a premature death within 5 years, within 10 years, that we know there's progression. But what we do know, regardless of any form of cancer, many patients have repeat recurrent hospitalizations. So when we call it malignant, we're really talking about poor health outcomes. But I wouldn't talk to my patient about it being malignant. What I would talk to say is, in your particular circumstance, if we don't get this right, you're at high risk of a premature death, you are at high risk of rehospitalization, and this is what we need to do together.
Okay, any more questions? Well, if not, let me congratulate you. I think it was an extraordinary lecture, and thank you